Hi, my name is Melissa, and I am a second career nursing student working on 5B this semester. I chose patient KG, who is a 63-year-old female. Patient is married and lives in a house with her husband and 17-year-old daughter. Patient is friendly at times, but rapid mood swings cause her to be easily irritated and uncooperative. Patient KG was admitted on November 12, 2014 to the emergency department at U of M with the chief complaint of altered mental status, loss of coordination, and loss of control of bodily fluids. Patient came in severely hypotensive with a blood pressure of 68/49. She was having severe diarrhea and vomiting resulting in hypokalemia. Emergency department also noted her altered mental status. The husband reports that she had increasing confusion over the two weeks previous to her admission. She had increased nausea and vomiting and diarrhea for the previous week and poor nutrition related to decreased intake by mouth. The emergency department documented her primary diagnosis as hypovolemic shock. Patient was admitted to the ICU on November 13th to stabilize and then moved to 5B on November 14th. I interviewed the patient on post-admission day number 7 when she told me that she had come into the emergency department because she was vomiting for a week due to the flu, which her family members had given her. She also states her ear was feeling plugged, which made her feel dizzy and added to the nausea and vomiting. She currently denies any pain or nausea. Patient greatly lacks insight as to why she is in the hospital and is a poor historian. This is in part due to her history of Wernicke's encephalopathy. Patient also has a history of alcohol abuse. Her past medical history also consists of hypothyroidism, psoriasis, paraneoplastic syndrome, osteolytic lesion of the right ilium, and a pulmonary embolism in 2011 due to refusing morphine treatment. Patient reported no childhood illness, and I could not find any documented in her chart. She is up to date with all her immunizations. She has 3 drug allergies, to citalopram, causing nausea and vomiting, Omnicef, which also causes nausea and vomiting, and she has an allergy to penicillin with potassium with an unknown reaction. Although she denies any previous hospitalizations prior to this current admission, she was hospitalized in November of 2011 for paraneoplastic syndrome. She presented with lower extremity weakness and associated sensory loss, gait instability, and lower extremity swelling, and cognitive changes. She was found to have low thiamine levels, but administration of thiamine did not improve her symptoms. Blood tests during her stay confirmed her diagnosis. Patient's current medications are as follows: ciprofloxacin dexamethasone, 0.3%, 4 drops in her left ear once a day. She's taking folate, a multivitamin, and thiamine. She takes 88 milligrams of Synthroid once daily for her hypothyroidism, 40 milligrams of omeprazole twice a day for esophageal irritation from alcohol abuse, 5,000 units of heparin subcutaneously 3 times daily to prevent clotting while in the hospital, and 125 milligrams of vancomycin by mouth every 6 hours for her ear infection. Lastly, she uses 2% miconazole powder for incontinence-associated dermatitis when needed. Patient perceives her health to be very good prior to this hospital admission. Patient states that she visits her primary care doctor once a year, but that she takes her prescribed medications only when she feels that she needs them. She doesn't like to take a lot of medications and would prefer to self-treat with Tylenol, aspirin, or Benadryl. Patient became offended and upset with me when I inquired about her drinking and smoking habits. She has a documented chronic alcoholism despite her stated consumption of only 2 to 3 drinks a month. She also stated that she smoked for 1 year during college and that she no longer does, although I saw that she had nicotine patches prescribed for her in the hospital. Patient denies any other substance use. In a documented note found from the social worker, patient admitted to heavily drinking during the last 2 years and states that it is related to a slow spiral downward in her mood since she left her fundraising job 2 years ago due to issues with the management. Patient says she does not like to exercise and that she sleeps an average amount every night. Patient has malnutrition and because she rarely prepares her own meals and relies on her husband, although patient appears to be average weight. Patient heavily relies on her husband and finds his presence calming and motivating while in the hospital to do activities such as walking. She states that she gets along with her daughter, but the daughter is very busy with horseback riding and school. Patient states that she goes to church every Sunday with her family, and her daughter attends a Catholic high school. Although patient believes that prayer is too religious and that's not something that could help calm her while in the hospital. The patient has a bachelor's degree majoring in communications. Patient stated that she loved doing fundraising as her job, and she still does it, even while in her hospital. Again, contradicting herself in her notes. Patient reports no family history of disease or illness, and there is none documented. The first system I chose to focus on was the neurological system and mental status, due to patient's altered mental status upon admission and current illogical statements. Also, her history of Wernicke's makes this a priority system to check. Patient is alert and oriented to self, date and time, and place, although she makes illogical statements and contradicts documented history. She states that she has no numbness or tingling and doesn't have seizures. She says she sleeps fine in the hospital, besides when people disturb her during the night for meds or blood draws. She states she has no anxiety and that she is ready to go home. She also states that she has no concerns about her memory or ability to concentrate. This is when patient became upset with me for asking and told me that she is a grown woman capable of taking care of herself. She states no difficulties with speech, no reported history of head injury, and only has tension headaches occasionally from stress. Patient admits to being unsteady on her feet, but believes that with practice and a good pair of grippy slippers, she will get better. For the physical exam, I found that her pupils were 3 millimeters and that they were round, equal, and reactive to light, and they were accommodating. Patient refused to do the mini mental state exam, feeling extremely offended that I would question her mental abilities. Patient had a slightly disheveled look, unkempt hair, and long nails. Speech is clear but illogical at times. Patient makes appropriate facial expressions. Face looks symmetrical while smiling, frowning, and raising eyebrows. Patient has a short attention span, sometimes trailing off while speaking for longer periods of time. Patient could not remember what she ate for breakfast 2 hours after eating it, leading me to believe she has impaired short-term memory. Due to her poor historian skills, I believe she has impaired long-term memory as well. Patient refused to draw a picture of a clock and count backwards from 100 in serial sevens. Patient seems to easily fabricate semi-realistic responses to questions, even though her answers may not be true. Patient was able to get up with 2 assists. She was unsteady on her feet and tired easily. Patient's upper and lower extremity fine motor function were intact. Patient had no decreased sensation on her extremities, although she no longer had the urge or sensation to void. Ankle clonus was not present, and patient is negative for the Babinski reflex. The second system I chose to focus on was the integument. Patient had a history of psoriasis and upon admission had notably dry skin and incontinence-associated dermatitis. Upon inspection, patient had dry and flaky skin covering her feet and legs. Patient states that this is not new for her and that she has dry skin all the time in various areas of her body. Patient says that she applies Nivea lotion on dry skin and it works well to help alleviate dryness. Patient is on no known medications to treat her psoriasis. Patient states that she has no concerns with her skin and that she's used to having itchy, dry skin. She also stated that she does not use many products on her skin and doesn't use sunscreen because she doesn't go out into the sun very much. To continue on with the inspection, skin was appropriate color for race. Her skin was warm, dry, and mostly intact. Skin looked clean, free from sweat and moisture, and free from odor. She had even hair distribution on head and arms and legs. Hair on head looked unkept, so we utilized the bathing cap to help clean it up. Nails looked smooth and attached. Fingernails had a cap refill of less than 3 seconds, and the toenails looked long and had nail polish on them, so it was hard to see the cap refill. Skin on her buttocks and perineal area was red and irritated, but still intact. Skin in that area was coated with barrier cream and miconazole powder, making it difficult to fully visualize all the skin. Upon palpation, skin was flaky on extremities. The patient had a small 1 centimeter by 1 centimeter superficial abrasion on the left shin and had a dry gauze covering it. Patient had scattered ecchymosis covering her extremities. There was trace plus 1 pitting edema on both her ankles. The skin had good turgor and no tenting was present. Other systems I believe that are pertinent to assess for this patient would be the genitourinary system. And this is due to her lack of awareness to void despite a full bladder and incontinence-associated dermatitis. Patient had standing orders to bladder scan every 6 hours and intermittently straight cath if bladder was over 250 milliliters. According to an article from the Israel Medical Association from May of 2013, it is important to find the etiology of dysfunctional voiding to normalize micturition patterns and prevent complications such as renal failure and recurrent infections. The other system that I would also assess would be the musculoskeletal system, due to patients' lack of motor coordination, unsteady gait, and history of alcohol abuse. According to the Biomed Central Research Notes from October of 2014, older adults experience high and increasing levels of alcohol-related harm. It is important to monitor patients' muscular strength and function to keep her living independent and able to perform activities of daily living. That is my presentation. Thank you.